Okay, let's go ahead and get started with grand rounds this morning. I hope everyone had a great weekend. It was a little bit wet, but Mother's Day is Mother's Day. So our first talk this morning is decreasing disparity with split liver transplantation. And it will be given by Dr. Jim Pomposelli, who's a professor of surgery in the transplant division and is director of our liver transplant program. He did his undergraduate training at the University of Rhode Island, medical school and graduate school, MD, Ph.D. at Boston University, then did general surgery at New England Deaconess, I guess before the merger, and then went on to do his transplant fellowship at Beth Israel Deaconess after the merger. He then was recruited to Leahy Clinic, where he spent 17 years and worked obviously very closely with Dr. Pomfret to build the largest living donor program in the country and one of the largest liver transplant programs in the country. We recruited him here about 5 years ago to lead the liver transplant program. He has done a terrific job. He has grown the program significantly, has really brought a living related, or I should say split liver transplantation to the forefront here at the University of Colorado. He is technically excellent. He's a great teacher. He's a great person, a great colleague to have around, especially when things hit the fan in the operating room. So with that, Dr. Pomposelli, please go ahead.
Thank you, Dr. Schulich, for that very generous introduction. I'd like to talk to you this morning about a new program we're starting here at the University of Colorado with split liver transplantation. This is leveraging our live donor program and experience into the deceased donor realm. By split liver, I mean splitting a deceased donor for an adult and a child or two adults. Now that's nothing really new, but what is new is some policy changes that we had something to do with UNOS and nationally, and we're doing a demonstration project here at the University of Colorado. I'll get into that. So I have no disclosures. So just a little brief history about liver allocation in the United States. Historically, liver allocation was based on waiting time and the acuity measure of the CTP score, or Childs-Turcotte-Pugh, which, as you may recall from medical school, has 3 laboratory and 2 subjective measures of ascites and encephalopathy. And at the time, basically patients had to wait about 2 years for a liver transplant. And that was really the major determinant who got transplanted next. The problem was the system was prone to gaming by exaggerating the subjective measures or placing patients in the ICU to increase their score artificially. And sickest patients were disadvantaged, especially if they were referred late. So it wasn't uncommon for a patient who waited 2 years to be called in from home, while someone sicker in the hospital did not get the organ offer because they were referred late. HRSA directed UNOS, the United Network for Organ Sharing, in 2002 to come up with a better system of allocation that would prioritize the sickest patients first. And the system that was ultimately adopted was the Model for End-Stage Liver Disease Score, or MELD score, which is totally objective. It's derived from 4 laboratory tests: the total bilirubin, the INR, the creatinine, and sodium was added later as a second iteration of the MELD score. And wait time was really de-emphasized as the third tiebreaker for sorting. And MELD score, which initially started as the Mayo model, it was derived at the Mayo Clinic, the Mayo model of end-stage liver disease, which was originally designed to predict mortality after a TIPS procedure. But it also has been validated and accurate as showing the 3-month mortality of patients waiting for a liver transplant. And MELD score did a lot of good things. Within 4 years of its adoption, median waiting times declined nearly 70%, and death rates declined by 20%. And it also had the benefit of eliminating race-based disparities that were documented in the pre-MELD era. And this just shows the curve of 3-month predicted mortality on the wait list by MELD score. And if you This line here shows about the rate of operative mortality, which is about in the 6 or 7% range for 30-day operative mortality for most transplants. And you can see these lines intersect at around a MELD of 15, which suggests that anyone who has a MELD score of 15 or higher would benefit from transplant. So if we could order livers online from Amazon Prime, we would obviously transplant everybody with a MELD score of 15 or higher. The problem is, here at the university, our median MELD at transplants around 28, which puts patients at around a 40 to 45% waitlist mortality within 3 months if they don't get a transplant. And because of this, about 15% of our patients die waiting for transplant. So obviously, we do a lot of things to try to increase the transplant rate, such as living donor transplant, and now more recently introducing the split liver program. But there are some problems with MELD score, and that is with sex and size differences in waitlist mortality. There's clearly an increased waitlist mortality among women and short-statured adults, and primarily that's because of the reduced muscle mass underestimates creatinine in women. So at the same MELD score, women could have less creatinine, so therefore their MELD score is underestimated. UNOS is now currently working on a third iteration of MELD score called MELD 3.0, which would correct the eGFR for females, but does not address the size issue. And if you look at this study of over 34,000 patients, the waitlist mortality for females is significantly higher. And women have about a 19% increased risk of waitlist mortality compared to men with the same MELD score. And height also contributes to this gender disparity as well. And here you can see the risk of waitlist mortality based on patient height. So short-statured adults, and those are adults less than 5'5", have a higher rate of death on the waitlist compared to taller people, 28% versus 24%, and lower rates of transplantation. And after adjustment for clinical and demographic criteria, height less than 166 centimeters or 5'5" remained associated with an 8% increased rate of waitlist mortality. And the authors in this study concluded that short candidates may be motivated to explore split livers or living donors to get them transplanted. And this slide here just shows, this graph here shows what happens even within one family. So here I am, I'm 5'11", and I actually have the lowest waitlist mortality based on my size. And my sister, who's 4'11", has a waitlist mortality about 25% higher risk compared to me. So height and sex are major factors on waitlist mortality. So what about split liver transplantation as a remedy? Just a brief history. Split liver transplantation was introduced in 1988 by Rudolf Pickelmeyer in Berlin, who enabled transplantation using one donor for two recipients, a pediatric and an adult patient. Unfortunately, Dr. Pickelmeyer actually died at the World Surgical Congress in Acapulco in 1977 when he went out for an early morning swim and drowned, assumed he had a cardiac event. In the same year, Henri Bismuth from France and colleagues performed the first full right-left split to transplant two adults. And these techniques got rapidly adopted by the transplant community. So what are the different types of split liver transplantation? So when we talk about splits, we're talking about taking left lateral segment off for a child, and then the extended right lobe graft can go to an adult, or we can do a simple, straightforward left-right split. In the past, people have done what's so-called cut-down transplants for pediatric patients, where they'd split off the left lateral segment and then discard the extended right graft. And this is a practice that really should be abandoned and abolished, since to waste an extended right graft is really a sin. Living donor liver transplant, something we do here, is the gold standard. It really has the best outcome of all transplants. And what we're talking about today is really deceased donor splits, doing an adult and a child, or 2 adults with a left and right lobe split. So UNOS does have a split liver policy in place since 2007. Every OPTN match run, so that's when they run the list to see who's up for the liver. If the donor has certain characteristics, such as they're less than 40 years old, they're only on a single press or less, their transaminases are relatively normal, and they're relatively thin, OPOs, or the organ procurement organizations or the organ banks, are encouraged to contact accepting programs and say, hey, will you split this liver? The problem with this policy is that if you split the liver and you go through all the work of splitting the liver, the remnant piece goes back into the donor pool for reallocating. Now you might think, well, that's fair, but it really reduces the incentive to split because there's nothing compelling you to have to split for your primary patient. And these criteria are somewhat arbitrary and not entirely based on data. So what's the experience in the United States? From 1995 to 2015, there were 113,000 deceased donors recovered. Of these, only 1.36% were split. 93% of these provided a graft to a pediatric recipient, which is good. But during the same time period, 6.8% of the whole liver transplants were used in pediatric recipients. A lot of those were cut downs where the extended right graft was discarded. And this just shows how deceased donor split liver transplants has happened over a recent 6-month period by region. We actually live in region 8, and this is showing splits by the recipient age. You can see the vast majority went to pediatric patients under the age of 18. And you can see even over a 6-year period, only about 1,000 livers were split, and probably closer to, that's only a little bit more than 1% that were split. So why so few splits in the United States? There are plenty of disincentives. There's little benefit if you're not affiliated with a pediatric program. Second graft goes back into the pool. It's technically challenging operation. Many hospitals where we're doing these procurements don't have proper instrumentation and technology. And that's where we have an advantage here at the university because our OPO has a dedicated procurement center. And we'll talk a little bit more about that later. And many programs are not prepared for the boomerang effect of the graft coming back. So, you know, the liver gets reallocated into the donor pool, and then an hour later you get a call saying no one wants it, you can have it. But you know, now you don't have a patient in-house. You have to set up a second surgical team and anesthesia team. The other potential disincentive is that there are potentially more complications compared to a whole liver graft. And it's perceived, although I don't think it's necessarily true, that there's worse patient and graft survival with split grafts. Sorry. So split liver remains an untapped pool for organs. If you look at data from UNOS, more than 20% of donors less than 35 years of age meet the current UNOS criteria. Yeah, like we said, only about 1.3, 1.4% of all livers have been split. And that certainly could help solve the organ gap. Right now, we have about 13,000 patients waiting for livers. We get about 9,000 donors a year. Not all those donors are organ or liver donors. Some of them are kidney only. So split liver and live donor could help close some of that donor gap. So some people argue, well, you know, patients won't accept a split. So if you look at the data between 2001 and 2015, there were 151,000 patients that were registered for a transplant, and 85% of them said they would take a split if offered one. And in 2015, 90% of the 11,000 registrants noted a willingness to accept a split liver. So how is split liver a remedy to address sex and size disparity? So UNOS is currently working on tweaking the MELD score with the so-called MELD 3.0, which will add some additional points for female sex. But simply adding MELD points for a female will not totally address the MELD problem, because it's not uncommon to have an extremely small female sit on the top of the wait list for an appropriate size donor. So deceased split liver transplantation addresses several problems simultaneously. One, obviously, it helps with pediatric organ shortages and provides an option for smaller females or short-statured individuals. It avoids living donor risk, which is a good outcome for a recipient, but puts a healthy person at risk. And obviously, if we can get 2 donors done with 1 deceased donor, that could help decrease waitlist mortality. But the issue is we need to incentivize splitting to realize maximal gain for both children and adults. So this brings me to the Region 8 split liver variants. That's something that I've been involved with in my position as the Vice Chair of Liver and Intestine Committee at UNOS. You can see Region 8, we're right there in the middle of the country with 6 states, very large region. And so Will Chapman, who's the chair at Wash U in St. Louis, and myself conceived the idea of doing a demonstration project with UNOS, the so-called Region 8 split liver variants. And we agreed that leveraging the procurement center concept, because St. Louis and Denver, we both have a procurement center. There's actually only about a half a dozen of these procurement centers in the country, and we have 2 of them. We agreed that we could leverage that and revitalize splitting for 2 adults. So we brought this concept to the Liver and Intestine Committee, where we said, if we split a liver, we get to keep both halves. We'll put the first split in the patient that it's being offered for, but we want to keep the second half, or the other part of the split, to either put into a child or in another adult. We brought that to the Region 8. All the programs agreed. UNOS said, okay, go ahead. We wrote up some policy language, went out for a public comment. Actually, before you could do any of these things, the majority of the 11 regions have to consent. I was surprised. There was actually some contentious public comment, but it narrowly passed. And then it was recently approved by the UNOS board, but restricted to Region 8. They were actually considering making it national policy and a national demonstration project, but right now it's restricted to us for 3 years as a demonstration project. Here's actually how the public comments were split, so to speak. The green are positive votes in each region. The reds are opposition. You can even see in our region, Region 8, 1 program opposed, which is kind of funny because we got unanimous consent before we started this. And some of the comments were, well, it's not fair if you don't have a pediatric program, and why should you get to keep both halves? And my answer to that is that if you have a liver offered to your primary patient, there's no law or rule that says you must split it. I won't bore you, but this is the actual language that basically says if the liver is allocated to your top patient, if you want, you can split it. And if you split it, you get to keep the other half, and you could either give it to an affiliated pediatric program or put it in a second adult anywhere on your list. So the question is, do split livers have worse outcome? This was a single center study done by Abi Humar, where he took, this is when he was in Minnesota, and he had donors at his own hospital. He split 6 deceased donors, transplanted 12 adults, and showed that they had very good graft survival rates, around 83%. There were 2 deaths, one from hepatic artery thrombosis and the other one from sepsis. And this is a larger study also done by Abi Humar in Minnesota. Between 1999 and 2005, they did 384 split liver transplants. 384 liver transplants. Some were whole grafts, some were split grafts, and some were living donors. And basically, they show they had excellent outcomes with all 3 different types of transplant, neither graft type nor donor source were a significant independent risk factor for patient or graft survival. And this just shows their patient survival. You see the living donors at the top actually had the best outcome, and split and whole grafts actually did equally well. And this is graft survival, basically showing the same thing. So Dr. Humar concluded that our data suggests that the status of the recipient is probably more important to determine an outcome than graft type or donor source. And that's something that we always talk about in our M&M. People, we always have all these conversations about should we accept fatty livers or marginal grafts. And I like to point out, usually at M&M, we don't talk about, gee, if we had just put a better graft in the patient, we normally talk about we had a poor patient choice as the reason for a bad outcome. And recipients of split liver transplants do very well. This just shows the difference between staying on the wait list, which is clearly the riskiest place to be, versus a whole liver graft or a split graft. This data also shows that you really need to make sure you transplant enough liver volume greater than 580 grams in the graft, do better than if the graft is obviously too small. And this is 100 consecutive split liver transplants out of 1,000 done at the center. Are there limits to splitting? Well, this was an interesting study where 16 pediatric recipients received a split graft from donors less than 7 years old. So these are very tiny donors. Mean follow-up was relatively short, but during this time period, they had excellent 100% graft and recipient survival. So even with pediatric donors can be split as an effective means of addressing very, very small recipients. So there have been some new suggested guidelines for split liver transplantation. This was a study done up in Seattle. Scott, I think Scott Biggins was on this paper, who used to be here as a hepatologist. And they just looked at what were the causes of graft failure after splitting. In this study, they showed that very young donors, unlike the previous study, 3 to 10 years old, older donors, interestingly, greater than 30 is considered an old donor in this study. A different program doing the split, which gets back to what I was saying earlier, that a lot of programs don't want to split if they weren't involved, so the liver often boomerangs back to the splitting program anyway. Longer cold times, it increases graft failure about 4% per hour. The graft sits on ice. Inadequate donor recipient size matching and program experience. If you had done more than 23 splits, you were considered an experienced program. So how do you initiate a successful split liver program? First, you have to solidify team commitment. You have to establish institutional support. You have to meet with your colleagues such as anesthesia, blood bank, OR, PACU, SICU. Let everyone know that we might have days where we're going to be doing 2 transplants simultaneously. That means people that are not on call might have to come in and help. We have to make sure we talk to patients about it up front. Most patients will agree. We're now in the process of patient selection. We identify our index patient who will be the target of the split, usually a patient with well-compensated cirrhosis, but maybe has a tumor, which puts them at the top of the list. And then we identify a second recipient, maybe a small woman or a child over at Children's Hospital. So we have the so-called split list. And then we have to collaborate with our OPO, the procurement center, who needs to provide some technology investment to help us do this project. And I would like to give a shout out to Donor Alliance, who is our Oregon OPO or Organ Bank. We discussed this with them, and they were very excited, and they invested over $1 million. They purchased a CT scan so we can do volumetrics on potential donors, because about 85% of the deceased donors in our region go to the procurement center. They invested in instruments and basically recreated our transplant liver set. They bought us a Thompson retractor. also an Irby hydrojet for splitting the liver, harmonic scalpel, and argon beam. We have the ability to do on-table cholangiogram. So Donor Alliance has really been generous in helping us further this project. So in summary, split liver transplantation can expand access to life-saving liver transplants in the United States. This is particularly relevant to children, short-statured adults, and women. A successful split program requires adequate resource investment and commitment by the local transplant community and the hospital. Use of updated split liver guidelines will help equip procurement centers and can promote safe expansion of split liver transplantation. So the key to successful is, as Yoda said to Luke Skywalker, there is no try, there's only do. So thank you for your attention. I'm happy to answer any questions.
Thank you, Dr. Pomposelli. Jim, that was a great talk. I encourage people to put questions up. It looks like Dr. McIntyre has one. Can you tell us how many splits have now been done in Region 8 with your new initiative? Any information on initial experience? The data you show says the program keeping the split does better support the new rule.
Yeah, so we just actually are just about to roll this out. As you can imagine, getting things through UNOS took almost 2 years. Everything's done. It's like going to City Hall. So to get the policy through took about 2 years. And we're finally now with Donor Alliance have all the pieces in place. So we haven't done any splits yet under the new policy. We almost had one last week, which would have been our first with Children's Hospital. So my hope is now that we have all the pieces in place that we can really ramp up pretty quickly. Obviously, we have to wait for the right donor and the right recipient pair.
So historically, how many are done here a year? You know,
it's changed because liver allocation here has changed. I showed you the graph. The 6-year data had about 80 in Region 8. That was the prior allocation system. Recently, we went to a new allocation system called Acuity Circles, which is now allocations based on circles around the donor hospital, not region anymore. So, so my fear is with the new allocation system, it may actually drop, but now with this new policy, hopefully we can keep it as much or if not increase it.
And so what about the ethics of a person saying no to splitting the liver, where that liver and the recipient meet the criteria for having a split? So, you know, potentially they are condemning somebody else on the transplant list to death, where they take almost no chance or minimal chance by undergoing a split liver transplantation. So that doesn't seem totally right, but it's a very, you know, there's so many moving parts and so many different vectors there. It's hard to get control of that.
Yeah, the problem is that you can't compel a program to split because not every program has the technical ability to do it, you know, the technology, the experience. So you know, being on the receiving end, when I was in Boston of some splits, you know, we accepted them. And, you know, it's like Christmas. You open up the box and you say, oh, this looks great. And sometimes you open up the box and it's like an ugly sweater that you want to send back and you can't. So the way the rules are now, you can't compel a program to split. And that's probably a good thing because not everyone can do it.
But from your talk, it sounded like the patient also has a significant say. I mean, if the program is expert at doing it, all the parameters are right, you know, ideally, if you looked at things globally, this liver should be split, but the patient says, nope, don't split it. You know,
yeah, that doesn't happen very often, to be honest with you. You know, I think it depends on how you present it, but you know, when I see patients in evaluation, you know, I make it very clear to them that, you know, the worst place to be is on the list. And any transplant whether it be split, live donor, or donation after cardiac death, which is arguably the kind of the worst transplant, is better than being on the list. So in my personal experience, patients are like, "Hey, whatever you say, doc, I'll take it."
Okay.
So I haven't had a patient say, "No, I only want this one or this one." They don't do that usually.
They trust you. Actually, Dr. McIntyre, you're online. I should have had you ask your question. You have a follow-up question too.
Yeah, could you just, this is very tangential to the goal of your presentation, but would you just give us a little bit of information about how this procurement center works?
Yeah, so there's about a half a dozen of these procurement centers in the country, although it's a growing trend. And basically it's over in Lowry, and it's sort of like a mini ICU hospital. So the Organ Bank has arrangements with most of the donor hospitals where if someone is declared dead, they're transported either by ambulance or even by flight to the procurement center. And then organ, procurement can happen in a controlled setting, and it's, outside the hospital setting. Most hospitals are very happy to get, basically a deceased person out of their ICU to free up a bed. So it's a win-win situation. And it's also a cost savings for the procurement center because now they're caring for the patient, under their own roof. So it's really a fantastic innovation. It's something I wish I had, when I was in New England, because, I can remember flying up to Bangor, Maine on a snowy night and, to go do a procurement. So, and around here, flying over the mountains, during the winter, to go to, Grand Junction or something like that, it's a little bit dangerous for procurement teams. And, there have been crashes of procurement teams. You probably, hear about them once in a while in the news. So this procurement center idea is really fantastic and a great innovation.
Great. Well, Dr. Pomposelli, thank you so much. That was a great talk, and we look forward to hearing data in a couple of years on how this new program is going. Thank you.
Thanks very much.
Great job.